Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, and today we'll be discussing non-histamine mediated angioedema. I believe this is a very important topic both for the boards and for real-life practice. I have no conflict of interest regarding this presentation. Please take a second to review the disclaimer regarding this presentation. The agenda for today's talk includes pathophysiology, etiology, clinical presentation of non-histamine-mediated angioedema, management, and diagnosis. Similarly to anaphylaxis, angioedema represents a medical emergent condition, and diagnosis should only take place after the acute management and stabilization of the patient takes place. So what is angioedema? It is non-dependent edema or swelling of the skin and subcutaneous tissues. What do we mean by non-dependent? Basically, it is unrelated to gravity. It is not mediated by histamine in the cases of non-histamine-mediated angioedema. It can also be a part of the histamine-mediated allergic reactions, such as anaphylaxis, for example. Our today's talk will cover non-histamine-mediated angioedema. And here on this slide, you see two pictures of two separate patients with angioedema, swelling of the face, lips, and tongue. On this slide, we'll describe the pathophysiology of angioedema, both histamine-mediated and bradykinin-mediated. On the left part of the screen, you see a brief and oversimplified representation of histamine-mediated reactions, which are a result of histamine release from mast cells and basophils, resulting in tissue edema due to vascular hyperpermeability. On the right side of the screen, you see a description of bradykinin-mediated angioedema. Factor 12 is very important in activation or formation of kallikrein from prekallikrein. In turn, kallikrein activates kininogen and converts it into bradykinin, which in result through bradykinin 2 receptors leads to vascular permeability and tissue edema. Angiotensin converting enzyme, or ACE, is important in the degradation of bradykinin. On this slide, you have a slightly more in-depth view on the non-histamine-mediated angioedema with different mediators and chemical pathways. You can also see that some potential targets for medications which can be used in the treatment and prevention of bradykinin-mediated angioedema. Please take a look and take some time to review the slide. The etiology of angioedema unrelated to histamine includes congenital or hereditary causes, such as C1 inhibitor deficiency and cases with normal C1 inhibitor levels. Most commonly though, or more commonly though, angioedema is related to medications. Classically, angiotensin converting enzyme inhibitors or ACE inhibitors. Some other medications are also implicated in the development of non-histamine mediated angioedema, such as dipeptidyl peptidase 4 or DPP4 inhibitors, typically used in the management of type 2 diabetes, fibrinolytic medications such as alteplase, which can be used in the treatment of acute stroke, and calcium channel blockers. The clinical presentation of non-histamine mediated angioedema usually is because of the swelling of the face, lips, tongue, and upper airway, or potentially the swelling of the gastrointestinal and bowel tract, which lead to abdominal discomfort, nausea, vomiting, and diarrhea. So, how does one approach the differential diagnosis of histamine-mediated angioedema, which can be part of anaphylaxis picture, to non-histamine-mediated angioedema? Usually, histamine-mediated processes and reactions occur at much faster rate and usually takes a few minutes to fully represent itself, especially in the case of anesthesia reactions. Non-histamine mediated angioedema usually takes much longer time to fully develop. Usually we are talking about hours. The rash is more common in patients who have histamine-mediated angioedema and is usually associated with itching. Rash is much less common in patients with non-histamine-mediated angioedema and is typically not associated with itching. Patients who have bradykinin-mediated angioedema, they do not usually have any hemodynamic instability, such as distributive shock, for example, and bronchospasm. Patients who have histamine-mediated processes tend to respond promptly to epinephrine, which is not the case in patients who have non-histamine-mediated angioedema. So let's do a case. You are asked to see a patient in ED. The patient has a history of high blood pressure, for which he was recently started on lisinopril. The patient presented to the emergency department with progressive facial, lip, and tongue swelling, which started several hours ago. The patient is sitting upright and reports progressively worsening difficulty of breathing. You notice that his O2 sat is 98% on nasal cannula. The patient is otherwise stable and has no additional complaints. So this is how the patient looks. The question is, what should you do next? You want to intubate the patient orally in the emergency department because you're concerned about the airway and think it needs to be taken care of right now. You want to give fresh frozen plasma or FFP and monitor this patient for resolution. Number 3, you give epinephrine and methylprednisolone. And number 4, you bring this patient to the operating room and you have your ENT or ear, nose, and throat colleagues for surgical airway backup. So the correct answer here is 4. This patient already manifested some symptoms which are getting worse. Unfortunately, the treatment for angioedema not mediated by histamine is not very effective in quickly abolishing the symptoms, which we'll discuss further. Intubating this patient orally in the emergency department probably is not the best idea given massive tongue swelling, especially without the backup of a surgeon. Fresh frozen plasma can be considered, however it takes time and acutely can make things worse, which we'll discuss more. Epinephrine and methylprednisolone are unlikely to be effective given that this is not a histamine-mediated process from the history stem. We anesthesiologists are considered to be experts in airway management, and patients who have angioedema with airway involvement are no joke for us. Again, you have to remember when approaching this patient is to know the patient-specific dynamics and trend. Is the patient getting better or is the patient getting worse? Is the swelling getting better or is the swelling getting worse? Also, it's important to know whether the patient has any signs of airway compromise, such as potentially stridor, or changes in voice, such as muffled voice, difficulty controlling secretions, difficulty swallowing, and worsening tongue swelling, because tongue swelling can sometimes lead to airway closure and obstruction. It's important to have your surgical colleagues, such as ENT. Remember that airway manipulation by itself, especially when things are so swollen and friable, such as in cases of angioedema, can potentially make things worse from attempts such as further swelling or bleeding. Consider using much smaller endotracheal tubes. Consider doing nasal approach, such as nasal fiber optic intubation, for example. Again, keeping in mind that it can lead to bleeding. Consider pre-medicating this patient's nares with vasoconstrictors, such as, for example, oxymetazoline spray, or known as Afrin spray. In certain cases, I think it's important to have a vena-venous ECMO as your backup for oxygenation and ventilation purposes. And again, it's important to remember that these are the cases not for a junior resident or medical student to practice. Again, have your ego very low and have the patient's best interests in mind. So we already discussed overall approach to management, we discussed the airway. Again, it's important to know the trends, the symptoms, and if time allows, trying to bring these patients to the operating room with your ENT or surgical colleagues as backup. Again, operating room environment has many potential benefits. Again, you have all the equipment there. You can get all the people you need, surgical ENT colleagues there. Again, if possible, stop the offending agent and triggers such as, for example, angiotensin converting enzyme inhibitor use. But again, keep that in mind. It probably will not result in drastic improvement, and it takes some time, sometimes days, to recover. Consider pharmacotherapy, and again, we'll talk about pharmacotherapy more. But again, unfortunately, compared to histamine-mediated processes, it takes much longer time for the medications to help you your swelling subside. Fresh frozen plasma can be considered when you don't have these medications available, or you find them costly. And obviously, good supportive care is also quite important and paramount. So first, let's talk about the C1 inhibitor concentrate. It's typically recommended to use in patients who have hereditary angioedema, but also can be used potentially in patients who have ACE inhibitor-mediated angioedema. As you can see on the right side of this slide with the pictorial, that C1 inhibitor decreases or prevents or minimizes the formation of bradykinin. This medication has limited availability and is quite costly. And also, all of the medications we discussed today, they are not immediately effective, meaning that it takes time, sometimes hours, for the medication effects to become clinically recognizable. Which means that if you think the patient needs to be intubated, don't expect these medications to potentially decrease the risk safely. If you think the patient needs to be intubated, you probably need to intubate this patient at the moment with appropriate backup, like described before. So the next medication to discuss is a medication called ecallantide. The mechanism of action is quite similar to the C1 inhibitor concentrate. On the left part of the slide, you see another pictorial showing different steps in the formation of bradykinin and different steps where medications can be effective. On the top right of the screen, you see that ecallantide affects kallikrein, which leads to a reduction of bradykinin formation. Similarly to C1 inhibitor use, it can be administered or considered in patients who have hereditary angioedema cases, and also patients who have ACE inhibitor-mediated angioedema. Of note, this medication is associated with about 2 to 3% risk of histamine-mediated reactions such as anaphylaxis, which can be concerning. And it's also quite expensive too. Again, the effects, even if successful, are not immediately evident or obvious. Another medication which can be used is a medication named icatibant, which is a bradykinin receptor 2 blocker. It can be used in patients who have hereditary or congenital causes as well as ACE inhibitor-mediated causes. It is also quite expensive, and the efficacy is not 100% and sometimes quite questionable. Tranexamic acid. There are some reports of use of tranexamic acid in patients who have hereditary and ACE inhibitor-mediated angioedema. Overall, this medication is relatively inexpensive and relatively safe, and we use this medication quite a lot in patients undergoing cardiac surgeries and orthopedic surgeries. On the right part of the screen, you see a pictorial showing the mechanism of action of tranexamic acid in regards to angioedema. The dose reported is 1 gram given over 10 minutes. Fresh frozen plasma, or FFP, contains angiotensin converting enzyme and C1 inhibitor. The typical adult dose is 2 units. Interestingly enough, it can occasionally lead to initial worsening after administration, so you have to be prepared to manage the airway if it happens. Again, FFP contains volume and is associated with volume overload, especially in people who are predisposed to that, such as patients who have decreased cardiac function or patients who have kidney dysfunction. Obviously, FFP is associated with all the transfusion-related adverse effects, something to keep in mind before giving FFP to the patient. Let's do another case. This time you're in pre-anesthesia clinic. Your patient is a 17-year-old female who is scheduled to undergo elective laparoscopic cholecystectomy. The patient is otherwise healthy, has no previous surgeries, and no family history of anesthetic complications. She has, however, a history of isolated angioedema requiring intubation in the past. She is not on any medications. Her mother also has periodic facial and lip swelling. The patient asks you about the cause of this and whether anything can be done to optimize your risk for the upcoming surgery. So let's talk about diagnosis of angioedema. I think it will help us understand what we can do to help the patient from the previous step. Angioedema primarily is a clinical diagnosis. You have to refer these patients to an allergologist for further workup. Again, just for our education purposes, some tests they can send include C4 level or complement 4 level, C1 inhibitor level, and C1 inhibitor function. On the right part of the screen, you see a picture explaining to you why complement level factor 4 can be decreased in the reaction of non-histamine mediated angioedema. And that is why C4 level can be useful in the diagnosis of angioedema attack. So you refer this patient to an allergy doctor who diagnosed her with hereditary angioedema. So what can you do to prevent the reaction from happening related to the procedure or surgery? We can break down procedures and surgeries into two main groups, such as low-risk procedures, which typically include dental cleaning and minor surgeries. High-risk procedures include any procedure or surgery requiring general anesthesia, dental procedures requiring infiltration of local anesthetics, any major surgeries, even if done under non-general anesthesia, and previous precipitants which triggered angioedema in the past. So if you have a patient who is considered to be low risk for angioedema, monitoring is probably all you need. For patients who are deemed to be high risk for angioedema, you can consider giving them C1 inhibitor approximately 1 hour before the surgery or procedure and then as needed. In cases where C1 inhibitor is not available, one can consider administration of fresh frozen plasma or FFP, keeping in mind all the risks potentially associated with that. Or if you have time, one can start danazol, which is androgen, approximately 5 days before and 3 days after the procedure. The mechanism of action for danazol is not very clear, but it is speculated that it can enhance the synthesis of C1 inhibitor in monocytes and hepatocytes. So in summary, non-histamine-mediated angioedema is a very rare condition. However, it can be associated with high morbidity and mortality, usually due to airway loss. Airway management in this patient is a high-risk procedure, but must be done when indicated, such as in cases where upper airway is involved, manifested by muffled voice or voice changes, stridor, difficulty controlling secretions, and difficulty swallowing. In addition, tongue swelling can be a sign of potential airway compromise. In such cases, involve your surgical colleagues, typically ENT surgeons. When things are taken care of during the acute phase and the patient is stable, refer them to an allergologist for long-term workup and management. For your congenital patients or hereditary angioedema patients, prophylaxis for angioedema is available. Again, thank you very much for your attention. And if you have any questions, please feel free to email them to me. I wish you all the best and good luck in everyday life and on the test. Thank you.